we get to introduce Dr. Neil Pliskin today. Dr. Pliskin is a board-certified clinical neuropsychologist, and he serves as a professor of clinical psychiatry and neurology at the University of Illinois College of Medicine. And he is also the director of both the neurobehavioral program and neuropsychology service. Dr. Pliskin is the former president of APA Division 40, and he is a well-recognized expert on the topic of electrical injury. Much of his research is focused on electrical injury as well as other forms of brain trauma. He also focuses on performance and symptom validity assessment and neuropsychological outcomes in various medical conditions. So again, we are so pleased to have you, Dr. Pliskin. We know that you've had several years of experience working as a neuropsychologist and training students like ourselves. So thank you again for speaking with us. Without further ado, I'll pass it over to you to get us started.
Wow, thank you very much. I thought I was talking to a student group. I'm seeing a few luminaries in the group here too, so the pressure's on. But I'm happy to talk today about my experience with electrical injury and understand that the task that I've been given today is to contrast electrical injury with other types of traumatic injury, traumatic brain injury in particular, for those of you that are planning a career that involves personal injury or workers' comp, and those of you that are already involved in that. So since I thought I was talking to a lot of students, I thought I'd begin at the beginning, and the rest of you are just going to have to go, I've heard him say that before. So electrical injuries, as far as occupational medicine goes, it's very limited in number, maybe around 4,000. But the issue is that a lot of the people that get injured or killed are young, employable men and women, in their 20s and 30s, so that when there's a significant injury, the value of that injury in terms of dollars and cents becomes much higher because you're talking about people with 30 or 40 years available for them to continue working. So, and then one other point is that electrocution is death by electricity. So you'll hear me talk about electrical injury, but electrocution is really after your heart stopped. So okay, let's jump in. I'm going to share with you my experience over the years. These are multi-system injuries. There's not only the neurologic and psychologic aspects, which I'll be talking about to the students today, but also there's issues related to vision, to burns, to chronic pain, and then the question also becomes, to what extent is cognitive functioning affected? And so electrical injury doesn't stop after the person gets out of the burn unit if they have that kind of injury. And those of you that already work on burn units know what I'm talking about. It's a long course of recovery. But also part of that involves disentangling what are driving the ongoing symptoms that people have. What role do psychological complications play? So, okay, here's the very basics of electricity. Okay, there's alternating current, which is depicted here, and then there is direct current, which is like the kind of current that you get from a battery. So people like to talk about, well, there's an entrance and there's an exit wound because there was a burn on one wrist and on the person's side. But the reality is that with alternating current, it cycles back and forth so many times per second, so that there is no distinct entrance wound and there is no distinct exit wound. There are multiple wounds from the alternating current. And here's the other thing. Those of you native Chicagoans might recognize this building, formerly known as Sears Tower, now known as Willis Tower, is a perfect way to illustrate the difference between voltage and amperage. People talk about, oh, this is a high voltage injury, and what they're talking about there is the field strength. But so if I climbed up to the top of Willis Tower and I dropped that feather off the side of Willis Tower, it would eventually make it to the ground. It would go at a certain speed. That's reflected by voltage. So the voltage can be very high, as tall as this building. But what really matters is the strength of the current going through, and that's amperage, as represented by a bowling ball. So if I dropped a bowling ball off the side of the Willis Tower, uh, it wouldn't be a good thing. And so when you evaluate severity of injury, don't be seduced by it's a voltage thing. The higher the voltage, the worse the injury, the lower the voltage. It's not. It relates more to the amps involved. And this is something that happens mostly again in the workforce, because in your house, you have something called a circuit breaker that will prevent these kinds of serious injuries from happening. So so electricity takes the path of least resistance. So skin has more resistance than the underlying nervous tissue. And so uh, as the electrons uh, travel up the nerves, they they cause pores to develop in the nerve and muscle cells that they pass over. And so there's a leaking of and sharing of intracellular and extracellular fluid space. And so that's where you start to get necrosis, cell death, um, and uh, incomplete recovery from physical trauma. So there's the thermal aspects of the injury. You know, the longer that you're in contact with it, the more heating there is, the more membrane protein denaturation that you're going to have. But the process of these pores developing in nervous and muscle tissue is is known in the literature as electroporation. And so electroporation of nerves is responsible for proprioception. And so that's why you'll see some individuals with electrical shock injuries who will develop balance problems. Also, um, you don't have to come into contact with the electricity, with the power source in order to get a shock. The issue is that if you're the shortest pathway to the ground, if there's some fault in the system, the electricity will come over to you. An example would be a patient of mine who decided to put up a high definition antenna on their roof, and they got too close to the power lines. And so the electricity arced over to the individual. So what you see is peripheral nervous system injury. And what's less clear is what happens in the central nervous system. And with some of these long fibers that traverse all the way into the so, all the way into the cerebrum, it's an open question. And so, but what happens in peripheral nerves is that there is regeneration. So the peripheral axons can, and the structural cells around them can regenerate, but they don't regenerate in the same manner, so that the injured neurons can also then be affected by an incomplete recovery. And that's why you get things like, oops, I wanted to show you this. And that's why you get changes in posture and locomotion, because when the brain reconnects to those spinal nerves, they don't necessarily connect in the same way. And so as a result, your spinal cord uh, demonstrates some changes that can uh, lead to you having falls. Also, because you're walking differently, now you got issues related to peripheral nervous system pain. And there's been a lot of work done in the peripheral nervous system of how electricity spreads, how the electrons spread, and what kind of damage they do. I like to just tell my story very quickly, which is I'm a clinician and an educator. And it's so interesting to me that somehow I became this expert in electrical injury, which started very much from a clinical standpoint, where someone at my institution at that time, University of Chicago, Dr. Raphael Lee, who's like an international expert on electrical injuries, a plastic surgeon and an electrical engineer, reached out through CNL psychiatry, saying that they had some patients that were exhibiting cognitive and behavioral changes. So after electrical injury. And so I did what any psychologist would do, or neuropsychologist, and that is I went to the scientific literature and was amazed to find that there was only like 3 or 4 studies that had been done, and the largest had like 11 people in it, and one of them, the outcome measures involved the Rorschach. So the next year, Dr. Lee asked me to write a book chapter on this, and I said, well, there's really nothing for me to say. There aren't really many studies. He goes, well, say that, which is what I did. And then suddenly, overnight, I'm an electrical injury expert. And I became involved with other clinicians interested in studying the effects of electrical shock injury, with the idea of developing a clearer sense of how to treat these injuries. So I've had great opportunities to travel around the world, and and uh, and I'm a clinician. I love it. So let me share with you my experience. I already know that many neuropsychologists have seen electrical shock injury patients. And sometimes they've seen 2 or 3 or 5. Um, but in the last couple of decades, the number, when the last time we went through this, was 185. And 82% of them are males, 91% right-handed, and they're high school educated, who then go on to become journeymen in whatever their construction area is. And to my point that I was making earlier, age here, if you have somebody who's injured and they're 43 or 33, the amount of money that will be asked to compensate for their injury uh, will be much higher. So even though there aren't as many occupationally based electrical shock injuries, thankfully, when they happen, they're very expensive. Okay, so this mirrors our, and I'll make this clear, and I'll say it a few times, our convenience sample. What I'm going to show you isn't a sample of people that were randomly experiencing electrical shock injuries. These were people who were having problems, who sought out the electrical injury program that was a joint effort between University of Illinois and University of Chicago. So in no way do I portray this as reflecting what every electrical shock injury patient's experience is. In fact, quite the opposite. So 121 of them had electrical shock injuries, and lightning is a different type of experience, and I'll be happy to talk about that at the end if there's time. 78% also had contact burns, and 22% never came in mechanical contact with the electricity. It arced over to them. And sometimes that can cause what's called a flash burn, where especially if you're out in the rain or your skin is wet, it can pass over your skin as much as it can go in. So 45% of our patients have contact burns. So let me word that another way. 54.3% come in with an electrical shock injury and no history of thermal burns. Some people fall off ladders after their injuries. Note, of our sample, less than half suffered a loss of consciousness. Oftentimes it's like there was an explosion, people came running over, there was a guy standing there, we asked him his name and he couldn't tell us. He was confused, but not unconscious. 62% were hospitalized, 30% required surgery, and when the electricity passes through your chest cavity, there's a risk of it disrupting the electrical rhythms of your heart and causing cardiac respiratory arrest. And this looks a little too symmetrical, but it's really true that out of this sample of 171 that we're talking about, 19 had a prior history of any kind of receiving psychiatric treatment. Oops, sorry. And I'm going to keep you guessing on what that was for a second longer. And many patients did not have any history of neurologic injury either. Well, the key thing I want you to focus on here is that these are people who work, they're in the construction trade. They work 6 days a week and overtime if they can get it. They would never dream of darkening the door of a mental health professional if they didn't need to. More about that later. But the key consideration for this talk is there a brain injury in addition to these kinds of catastrophic electrical injuries that people are exposed to? And the answer is sometimes it is. If you're in a closed space and like a basement and there's no circuit breaker and the power there's a short and it arcs over to you, it can heat up the air and cause a thermoacoustic blast. And for the skeptics in the group, which should be everybody, these are younger people. Many of them have significant injuries. Some of them come in, they have absolutely no injuries whatsoever that are visible. But it doesn't mean that they don't have an injury. And so litigation is a fact of life with this patient group. And um, so 79% of the sample is in litigation. And as you can see, thanks to the good work of Zach Resch and his mentor, Jason Sobel, we gave about 25 different performance validity tests to make sure that we screened out all the individuals who failed two or more validity measures. So yes, it's a convenience sample, but it's a convenience sample of electrically injured patients who are not trying to game the system. So let me get to the bottom line here. Here's what we know about neuropsychology and electrical injury after 2 decades. One, electrical injury results in cognitive dysfunction in many survivors that differs from traumatic brain injury, right? Here's your standard traumatic brain injury. You suffer an injury, you have a period of post-traumatic confusion, and then with the reduction in swelling, depending on the severity of the injury, there's a restoration of memory. When you contrast that to electrical injury, in traumatic brain injury, you have a loss of consciousness, but in electrical injury, you have 45% of the people with a loss of consciousness. Their post-traumatic amnesia only described in 30% of our sample. And in true traumatic brain injury, you don't see delayed effects typically unless they're due to secondary factors. Argue with me later about that if you want to. To me, the most significant acute effects occur around the time of the injury itself. However, that is not always the case with electrical injury. There are multiple case reports of delayed spinal cord syndromes that, and early on, delayed cognitive changes, although I think we have a much better understanding of what that is now. And in traumatic brain injury, you're looking for structural damage as evidenced by imaging. Whereas in electrical injury, our experience has been that structural damage is not typically evidenced when using even 3 Tesla magnets and MRIs. So electrical injury is not, it's a type of traumatic brain injury, but it's not a concussive, accelerating, decelerating traumatic brain injury. It just isn't. And so this issue of can you see delayed effects? And the answer is, of course, you do see delayed complaints, and people come to you with those delayed complaints, and that's what makes it a convenience sample. And we've studied these patients a lot over the years, and there's a whole bunch of them that come in who have not had an obvious electrical shock to the head, who have had some who have had thermal injuries, but many who don't, who come in with cognitive complaints. And in this case, the controls were healthy electricians matched for IQ. So these were some of the complaints that I would typically hear. It's not that I can't do things, it just takes me longer. I just saw somebody the other day who had substantial nerve damage to his elbow. He is a high voltage, high wire electrician, and those are the toughest people. And he stays on the ground now, but he still directs his team because he says it takes him too long to process things. I've had patients say, my brain feels like it's on screensaver, or what was automatic is no longer automatic. You can hear this with many different kinds of conditions. But when you start looking at the neuropsychological effects and you match patients to healthy controls, you see that the primary problems that they have are in attention and processing speed. And here's another piece of work, hopefully soon to be in print, from my good colleague, Zach Resch, looking at 35 individuals versus 35 individuals with electrical injury versus 24 veterans with PTSD and 25 veterans without PTSD. They were a squeaky clean group, and we looked at issues of processing speed, immediate and delayed memory, and executive functions. And we looked at the differences between the electrical injury group compared to veterans who had PTSD and versus those who did not across domains using these measures. And it wouldn't be a good neuropsych talk if I didn't at least put up some data. And this is Dr. Resch's data, which fails to show significant differences between individuals with electrical injury versus individuals with electrical injury versus individuals with electrical injury, sorry, with traumatic brain injury and post-traumatic stress disorder. So the electrical injury group generally didn't differ from veterans with CAPS confirmed PTSD. The differences, again, arise in processing speed, which underlies some of the verbal memory difficulties. And while we can look at it and say that there are nuanced differences between the groups, at the end of the day, post-traumatic stress disorder plays a very important role in identifying patients who are at risk for persistent cognitive sequelae following electrical injury. So the key point here is there can be neurocognitive changes. The neurocognitive changes are generalized and typically associated with attention, and processing speed. You don't see an amnesia. You don't see an aphasia. You don't see a dementia. What you see is a reduction, typically in individuals where the brain was not a point of contact, individuals who are coping with multiple things, the pain of their experience and the aftermath of it. They roll over, they can't sleep, they're taking medication, their mood is low. You look fine, you sound fine, you talk fine. Why aren't you fine? Come back to work. And yet the person, because of the trauma, physical trauma and emotional trauma, is faced with a tremendous dilemma. The thing that they're trained to do, they are afraid to do because they have post-traumatic stress symptoms or acute stress response. So the origin of cognitive impairment and electrical injury is very likely multifactorial. And if you don't take anything else away from this talk today, I'm a big proponent of integrated care and making it patient-centered integrated care. And so optimal treatment involves a team working together to disentangle what are the issues that are contributing to this individual's misery. You know, is it the direct effect of the electrical exposure? And I've gone through the rest of these already. And note when I put trauma, note I also say emotion regulation issues because one of the people on the call today, Max Obolsky, did his own study looking at the phenomenology of emotion regulation in these electrically injured patients, and they look a lot, and their symptom clusters are a lot like individuals who have post-traumatic stress disorder. Now you throw on top of that people who are experiencing chronic pain that affects their mood and affects their ability to focus, their bandwidth, and they end up showing problems with higher level processing and attention and processing speed. And that's not to say that's due to damage to their brain, although that's not to say that it isn't. And I'll make my best argument for why it might be a little later. Anyway, the fact is that electrically injured patients suffer significant emotional changes after their injuries. And sometimes it's in the form of post-traumatic stress. Sometimes it's in the form of coping with pain and the medications for the treatment of the pain. And sometimes it's just not clear why they're not getting better. And so over time, we've kind of disentangled some of what we now understand as a multifactorial type of injury. So an electrical injury patient's pain experience can influence their cognitive and emotional functioning. Again, that is not unique to electrical injury, but we're talking about electrical injury today. So we've looked at the injury characteristics. We've looked at severity of obvious physical injury. I had one patient who whose uncle died. They were working together installing optic cable lines, and as is typically the case, even if you do everything right, someone else may screw up. And that's what makes these injuries so unpredictable and so scary for people. But I had somebody who had both arms amputated at the shoulder and had to learn how to feed himself, using his feet, and dress himself using his feet. And I tested him, and he was cognitively normal. He had obviously adjustment issues, but cognitively normal. And yet you have other people who develop symptoms from different and oftentimes less seemingly complex injuries. And you go, well, what is that? Why does that happen? So what else do we know from 2 years of studying, 2 decades of studying these patients is that electrical injury survivors develop changes in mood and changes in their ability to manage and regulate their emotions. That looks an awful lot like post-traumatic stress disorder. And key point, remember, 18% of our sample had a prior psych history. Most did not. And when you ask them how they're coping, what you get is a lot of stress, anxiety, depression, anger, and attitude changes. And this is the work of Ilona Ramadi, who looked at 86 electrically injured patients and looked at their psychiatric morbidity following their electrical injury and its effect on cognitive functioning. So we had people with psychiatric diagnoses and without psychiatric diagnoses. And the first thing was that there are a substantial number of people who experience anxiety, depression, and post-traumatic stress disorder in this group. And since this is a forensic talk, it's very important that you rule these things out or in using symptom validity controlled measures, like the detailed assessment of post-traumatic stress or the trauma symptom inventory, or something else, the MMPI, whatever works for you, as long as there's some validity control to it. But what we see in our squeaky clean validity controlled group is that they're suffering psychologically. And 2 years later, people are still experiencing substantial difficulties. I like to talk about two examples. One is my 43-year-old firefighter from Kansas City who's standing on the second floor of a burning building putting out a fire. and he's holding a hose with an aluminum ring. And it's at night, they haul up a generator. Somehow the other end of the hose comes into contact and he sustains a electrical injury and an electrical burn. My second case is a 47-year-old person working as a mine foreman in West Virginia who one day is in the mine, comes across some faulty equipment, and sustains an electrical shock injury. And the thing about this mine foreman is that he was also an emergency medical responder. So when there were mine catastrophes, he was someone that would lead people into the mine. So you got one guy standing on the second floor of a burning building, putting out a fire, and another individual who leads people into the mines during a disaster. Both individuals, after their electrical injury, experience this emotion regulation difficulty, don't want to leave the house. They cry, they're upset, and they're unable to return to their work. And you go, well, okay, I get it, but I mean, these were people who you would consider to be kind of stress inoculated. But if that post-traumatic stress, that fear conditioning is strong enough, and that cortisol is released, it really sets people off. And so what we see is that 78% of our sample in the study by Dr. Ramadi had a diagnosable psychiatric disorder. And again, 18% came in with. So the prevalence of psychiatric morbidity increases with time. And maybe that's what's behind the so-called delayed effects of electrical injury is under-recognized factors that contribute to someone's alteration in their mood and their ability to focus and function. So, key point, electrical injury patients experience psychiatric changes and problems with emotional regulation. These symptoms are not a character flaw. They're not a sign of a weak personality. They're symptoms of emotional trauma and maybe more. Okay, going in the right direction now. I'm running out of time and I want to leave time for questions, but this was a study where we looked at people who had one diagnosis or multiple psychiatric diagnoses, and we followed them over time, doing multiple evaluations, and those individuals with the multiple diagnoses, no surprise, perform worse on all cognitive measures. So we know that electrical injury results in cognitive dysfunction. We understand that it's a multifactorial process that affects mood and emotions in some people, and that it affects, and that there are physical effects. And some of these physical effects remain a major source of disability for patients years later. And I'm not saying that they have brain damage that's causing them to have these physical and persistent changes. I'll give you my thoughts at the end about that. But all I'm saying is observationally, in following these people, it's a major source of disability. So when we tested patients twice, as I said, worsening depressive symptoms were a factor in why we saw problems with long-term adjustment to electrical shock injuries. So to conclude, what we've learned is that neurocognitive impairment is not typically the primary problem following electrical injury, but cognitive impairments can be verified, and you have to disentangle what that is. In some people, it's were they in an enclosed space? Did they have a blast injury? For other people, how significant is their pain and how many surgeries did they have to deal with their electrical shock? How well is someone sleeping and coping? What kind of support do they have? So when I talk to groups about this, I always say that, there's a lot of focus on skin grafts, um, and getting people better, but there needs to be early attention paid to the mood state in these individuals because some people have problems that persist and affect their ability to return to work. So in terms of best practices, I would say the questions are, is the person legitimate in their complaints? Is there a brain injury to go along with the electrical injury? Did they fall? Were they on a ladder? Were they on a roof? Is there symptom validity and performance validity controlled evidence of cognitive impairment? And if so, what's the psychiatric status of the individual and what's their pain status and the interaction thereof? So the optimal treatment involves a team to clinically disentangle and pursue proper diagnosis and treatment. And so for some people, it is going to be cognitive issues. In other people, it's going to be more pain. And for many, it's adjustment to illness and health anxiety with the ultimate goal of returning to work. And even in low voltage injuries, this came out of the group in Toronto, uh, showed that people return to work, but they don't necessarily return to work at the same level of job that they had before. Like the high voltage guy I told you about with the really bad elbows, he can't go up anymore, but he still is like a foreman and directs people. So what we know in conclusion is that early intervention from mental health professionals is essential to the outcome. So when you get these forensic cases and you have to look and see what kind of care have they gotten early on? Has there been attention that's been paid to their pain? Has there been attention paid to the medicines that they're using to treat their pain and their mood? And I think that earlier recognition and introduction of physical rehab reduces some of the electrical injury symptoms. And you want to create an environment where there's expectations for improvement. So what we don't know about electrical injury is why people have cognitive impairment who don't have chronic pain or who don't have the same kind of life complications or emotion regulation. And I always like to talk about the fact that the when you consider the kinds of treatment that are offered for people with medically intractable depression, it's exposure to an electrical field that induces a seizure that leads to alteration in brain chemistry and perhaps regulation of a system that was dysregulated. I'm talking about ECT, of course. That's and so in that scenario, maybe it's someone who doesn't have a dysregulated serotonergic system is exposed to a large electrical field and experiences changes. I don't know. My colleague, Dr. Lee, talks about the fact that when the spinal cord and the spinal muscles don't heal the same way because of the structural cells, the Schwann cells, that as a result, the type of communication that goes on between the brain and the spinal cord is altered. And that's his thing about why you see such issues with balance and coordination in these folks. But at the end of the day here, What I can tell you is that cognitive and emotional changes remain a source of disability. And if you're interested in forensic work, you're going to be exposed to these patients. And you're going to look at them and you're going to go, well, they didn't have much of a burn, so they must be okay, right? And in some instances, they're not. And when cognitive impairment emerges, you have to look at all the factors that might be contributing to it. Now, if somebody has a cardiac arrest and they have a hypoxic brain injury, that's a different story. Somebody falls off a ladder, that's a different story. But when it emerges in an electrical injury and there isn't an obvious reason for it at this point, the most that I'm prepared to say is that it's likely due to multiple factors. Now, we're involved in some studies now looking at even higher resolution imaging to see. Um, but at this point, I'll stop by saying that if you're a clinician, you're going to want to be attending to the early identification and targeted treatment that these folks need. And if you're a forensic person looking to evaluate the severity of an injury, don't measure it the same way that you would measure, oh, I love that one. Don't measure it the same way that you would measure a traumatic brain injury. They're different kinds of injuries. So I think I'll stop here right on time and see if any questions popped up that you would like me to answer.
Thank you so much, Dr. Pliskin. This is a really incredible and comprehensive talk, and I've certainly learned many new things. So I'll jump right into it. You might have touched upon this a bit, but is there a relationship between a delay in psychological treatment after injury and the manifestation of delayed onset PTSD?
Undoubtedly. I mean, I think that especially, so it starts out as an acute stress response and there's complete havoc in the family. And I mean, I've had people, who electricians who are afraid to screw in a light bulb shortly after this. So, um, so you look fine, you sound fine, you talk fine. Dad, why can't you pick me up? Dad, why can't we play ball? Mom, why are you always crying? So, okay. So the earlier the intervention and explanations, I think the better the outcome is going to be, even if it means intervening with the family and helping the family to understand. Because what happens is that there can be minimal skin breakdown and maximal damage that occurs subcutaneously. And that's why, these folks get EMGs to look for nerve conduction deficits. Okay, I think I answered the question. I see that there's a question about tasering. Um, God, George Prigatano and I were asked by I love telling these stories, by the Arizona State Police to do a study with them in conjunction with Arizona Forensic Institute. The first author is White, if you're interested in reading the study. But so they would do this daisy chain where they would hook arms on each side of the police officer because you're not allowed to use a taser if you yourself have not been tasered. That's actually a rule, at least in Arizona. So what ends up happening is that they asked us to do a pre-post study on them. And what we found was like in the first like 10 minutes, digit symbol was like a little bit slower. I mean, so they were like a little confused initially, but there really was no, and then like we tested them like an hour later, and there really was no effect that persisted following tasering. Now, I've had cases where, individuals have been tasered like 8 or 10 times. And then, and they say, well, could that cause an electrical injury? I don't know. I know that the tasering temporarily disables and sends competing signals to your spinal cord, which is what causes you to flop down like that. But um, I'm no electrical expert, so I can't answer that one. What else you got for me?
We also had a question, are you aware of any ethnic or demographic differences in the presenting problems following electric injury?
Access to care, for one thing, familiarity with with navigating the workers' comp system. Um, if the individual has English as a second language, which happens very often, then there's complicating factors with people not fully understanding what their rights are. I've seen individuals, who you have to remember that workers' comp makes their money, their job is to get you back to work. That's what their job is. And you have some wonderful workers' comp nurses, and then you have some, ones who are just like push you, call you every day. And then, the individual feels like I'm useless just sitting here. So they go back to work and then they promptly get fired. Um, and I'm not going to say that um, I'm going to say that the differences relate more to familiarity with the healthcare system and how it works. And if English is a second language and you're trying to navigate the healthcare system, it can be highly, highly problematic.
So
Let's go
you had
ahead.
touched upon this a little bit, but could the symptoms and effects of electrical injury also be relevant for patients who are getting ECT? And the question's being asked since it might give insight to neuropsychologists who wish to conduct more precise pre and post ECT assessments, focusing on cognition and mood.
There's a lot of studies that have been done looking at pre and post ECT and its effect on cognition. And uh, certainly without question, when someone's in the middle of a course of ECT treatment, they there is absolutely a disruption in attention and processing efficiency during that time, not only immediately around the actual ECT treatment, but also during that time interval when they're receiving multiple treatments a week or a month. And but I'm not aware of studies that have shown that there are residual long-term effects associated with the ECT alone. And of course, you have a problem with disentangling that for the reasons for the ECT, which is chronic depression and probably long-term exposure to psychotropic medications. So maybe there's people on the Zoom call today that have a better understanding of it than I do. But I don't think that ECT, you're talking about a small electrical field, and and uh, applying a field that's like slightly larger than is necessary to induce a seizure. And, is it the seizure that leads to the alteration in mental status and in emotional status? That's the question.
I think we have time for maybe two more questions. So do you find that in this population, there's a big discrepancy between subjective cognitive concerns and the objective cognitive test data? And what role do you think factors such as pain, sleep disturbance, and emotion dysregulation play in this discrepancy?
Yeah, what a great question. And the answer is affirmative, without question, that you have to disentangle uh, what the different effects are of of these conditions. I mean, you march 100 people into your office with low back pain and who wake up 5 times a night because of they turn over, and you give them cognitive tests, they're going to look an awful lot like our electrically injured patients do. Um, so yes, I think that's really the whole point of the talk is that you have to approach it. For me, I'm not a skeptic because I've seen a lot of these folks, and maybe some of you who work on defense or will work on defense, will see one kind of patient. And those of you that work with plaintiffs' attorneys will see other kinds of more acutely injured patients. But there's a range, and 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 really contained within that range, you have to attend to emotional status, pain status, sleep status, and whatever the effect of the electrical exposure is. I didn't talk about our one functional imaging study, and I'm not going to today. I mean, because the reality is that behavioral measures alone will not answer this question. But we have multiple ways to recognize what the issues are and to help people get better than they are now. And that's by legitimizing what their experience is, but not necessarily buying into there's brain damage that's producing this problem. I think that the jury is still out on that, and anybody who tells you otherwise, um, you know, I don't know how they could reach any conclusion like that. There's basically the Chicago program, there's one in Toronto, there's one in Paris, and then there's one in China. That and I've talked to many psychologists on burn units, who see these individuals also. But they're different kind of injuries, and they're always going to be. What I've learned is they're always going to be multifactorial. So this is a forensic talk. So you have to have a certain degree of skepticism in what you're saying. Um, but before you dismiss it, make sure you cover all your bases. Okay?
The last question we have for you is if you could just speak to any efficacy with typical PTSD treatments, such as prolonged exposure or cognitive processing therapy, or more generally, just what type of supports are out there for these individuals and their families.
Yes, I've definitely seen people get better using trauma-informed therapies. Uh, and uh, and I've seen people get better when they've had like spinal cord stimulators put in. The one cannot underestimate the role that chronic pain plays in these patients. So, yeah. Well, I hope this was informative. I tried to keep it forensically focused. My take-home message is traumatic brain injury and electrical injury, not the same thing. Don't get seduced by loss of consciousness and post-traumatic amnesia, but rather look at things like severity of injuries, the multiplicity of complaints, what kinds of burns that they've had, and was there any cardiac involvement in these patients? Okay,
Thank you so much, Dr. Pliskin, and thank you so much, everyone else, for joining us today.
take care, everybody, and stay away from power lines.